Hi, my name is Dave Foster. I want to introduce Dr. Malcolm Feigen from Melbourne University in Australia. Dr. Feigen is going to be talking about radiation therapy in patients with mesothelioma, many of them who had failed traditional therapies. So I'm going to let Dr. Feigen speak for about 45 minutes, and then we're going to entertain questions. Thank you.
Thank you, Dave. I come from the southeastern part of Australia, and I'd like to present some work that we've been doing for the last 8 years on patients with pleural mesothelioma who haven't had, in most cases, major resections nor much chemotherapy. So this is from our database looking at the incidence and outcome of patients diagnosed with mesothelioma in Victoria, Australia, and it shows that since 1990 there's been no impact of any medical treatment modality on the survival in this disease. So whether you were diagnosed in 1990 or 2004, your 5-year survival is still limited to 5%, and half of the patients die within 12 months of being diagnosed. So on this background, we were looking at other methods to manage this disease. Most of the audience knows these facts about mesothelioma. At the moment, there's no curative treatment, there's no standard therapy. A lot of the disease symptoms are related to local progression in one side of the chest, and most of the treatments that have been offered risk major toxicity and have only modest benefits. There is a role for radiotherapy that's been recognised in patients who have pneumonectomies in a post-operative setting, and this has been shown to have an impact on local regional recurrences, but there may be a risk of significant toxicity. The data that's been published to date on patients who have pneumonectomies in most cases, followed by radiotherapy, shows that the older methods had very little benefit. And the major change in that was from MD Anderson when they analysed a series who had a relatively new type of radiotherapy called intensity modulator radiotherapy, and when they gave this to patients who had pneumonectomy, the rate of local failure came down from 5% compared to other cases which are anywhere between 50 and 100%. So it was on this background that we decided to introduce similar treatment to the patients I was seeing in Australia. However, this isn't widely appreciated, and I've just put up this quote from a website which looks at the role of radiotherapy, and this comes from the International Mesothelioma Interest Group, which every 2 years has an international meeting, and this is from the recent website page about radiation therapy. Although in vitro studies suggest that mesothelioma is more sensitive to radiation than non-small cell lung cancer, the clinical experience reported by radiation oncologists suggests that it is an especially radioresistant tumour. In addition, radiation of the involved chest is limited by the presence of radiosensitive organs and the extensive nature of the tumour. As a consequence, its use appears limited to adjunctive therapy for patients who have undergone extrapleural pneumonectomy and to palliative treatment of painful chest wall lesions. Prophylactic chest wall irradiation may reduce the incidence of chest wall recurrences at incisional sites, but there is no consensus on its use, and randomised controlled trials are needed. And this is the general belief in radiotherapy that's reflected in most of the textbooks and journal publications, which reflect experience that may have been valid 20 years ago based on old radiotherapy techniques, but we've been able to make some modifications to this with recent technological advances. So since I've been dealing with this disease and treating the patients who I'll show you later, I've been able to address some of the misunderstandings about the role of radiotherapy in mesothelioma, and in the rest of the talk I thought I'd deal with these by going through 10 common myths that are reported widely in the medical literature, which I've been able to find are no longer accurate. So I'll deal quickly with some of these points, and that will be the basis of my talk tonight. I come at treating mesothelioma from a hospital that has specialised in doing parectomy decortication with photodynamic therapy. And here you can see that the results aren't very good. The surgeons weren't very keen on doing pneumonectomies, and I decided, after I heard about some early results from MD Anderson, to look at giving radiotherapy to patients who'd had surgery, but I was unable to convince the surgeons that they needed to do a pleurectomy first. So I started off treating the area that was at high risk of local recurrence, which was usually around the diaphragm and costophrenic recess, by giving high doses and evaluating the responses by doing PET scans on all of my patients. So the eligibility criteria have been basically patients with reasonable performance status. They had mesothelioma that was active and showed up on PET scans. We took any histological subtypes. Most patients had incomplete resections with various amounts of residual disease, and we discussed all cases with surgeons, medical oncologists and radiation oncologists before we exposed them to this treatment. This is the first patient I treated back in 2003, a 72-year-old man with stage 3 mesothelioma based on the PET scan. Most of my patients don't have pathological staging. And after pleurectomy decortication, this was the area that showed activity on the PET scan, which I decided to irradiate. And this is the volume that received 50 Gray. And when we did another PET scan after 4 months, we found that the activity was reduced in the area that had been irradiated, but it showed positivity in areas beyond that. Now, I've had a software program used to evaluate the activity of the FDG glucose on the PET scan by measuring the volume that shows up and how high the SUV is in that volume, which we've been able to assess only within the area that had full dose radiotherapy. So in this case, you can see the number is 393 from the activity in this area, and on the next PET scan that's fallen to 84. So I've been able to quantitate this as a 78% response to radiotherapy without having any chemotherapy in the equation. And we've been able to analyse a number of patients in the same way to get an idea of what response we can get from radiotherapy alone. So since most of the other published work on radiotherapy has been done, we've advanced in quite major ways that some of the surgeons will appreciate from dealing with non-small cell lung cancer. We've gone from 2D to 3-dimensional radiotherapy, and now we're doing 4-dimensional radiotherapy where we can make allowances for respiratory movements. We've introduced CAT scans to plan all our patients, in many cases PET scans as well. And we do daily imaging to see about patient movement, and we have much better software which allows us to give higher doses to larger volumes and spare the organs that may be at risk of damage from high doses of radiotherapy. The patients I've been able to treat on this program are shown here with the broad details. There have been 37 patients ranging in age from 37 to 74. As in most series, most of them have been males with right-sided epithelioid mesothelioma. What's different about my series is that apart from 5 stage 2 patients, they've all had advanced stage 3 or 4 disease. So that's 92%, which has not been published in any of the surgical or other literature. Only 2 patients had extrapleural pneumonectomies. The majority had pleurectomy decortications. The earlier patients combined with photodynamic therapy. And these patients had limited surgery, which was confined to wedge resections or pleurodesis. And I've had 2 patients who've had no surgery whatsoever apart from a biopsy. When we started back in 2003, chemotherapy wasn't looking very good, and most of the patients didn't agree to pay to have pemetrexed until it was put on the pharmaceutical benefit list. And since 2007, most patients have been having cisplatin and or carboplatin with pemetrexed before they've seen me for radiotherapy. However, of the patients who've had chemotherapy, Very few have had it before or immediately after surgery. Most of the patients have needed it for palliation before they've actually come to see me, and they've progressed. So that's made them even more advanced than most other series. Half of the patients had 3D conformal radiotherapy, and since 2006 we've introduced intensity modulator radiotherapy, and I'll detail the response in some 14 patients whose PET scans I've been able to analyse before and after they had their high-dose treatment.